The next speaker is Dr. Deepa Kattisettar. She is present Associate Professor, Department of Anesthesiology, MMC Mysore. She had a publication in international and national journals, special areas of interest, pain management and labor anesthesia, and completed MBBS from MRMC Gulbarga and diploma from JNMC Belgaum and DNB from Pondicherry Institute of Medical Science. Over to Madam.
Thank you, sir. Good afternoon, everyone. My topic for today's discussion is foreign body in a pediatric airway, how I manage. Aspiration of foreign bodies by children is a common problem around the world. It is seen under the age of 5 years more frequently, and peak incidence vary between 6 months and 3 years of age. More frequently seen among boys due to their increased physical activity. And asphyxiation from inhaled foreign bodies is a leading cause of accidental death among children younger than 4 years of age. Now, managing a pediatric case with a foreign body aspiration presents unique challenges to the treating anesthesiologist. Now, what are these foreign bodies? More than 90% of the foreign bodies are organic in nature. They are mainly divided into organic and inorganic foreign bodies. The organic foreign bodies are peanuts, custard apple seeds, tamarind seeds, seeds top the list. Then beans, grapes, non-organic foreign bodies like coins, safety pins, hairpins, battery cells, even pebbles and small toys have been aspirated by children. What are the risk factors contributing to aspiration in this age group? First is incomplete dentition, immature swallowing coordination and inadequate chewing process, tendency to be easily distracted while eating. The child will be running around or playing. With increased ambulation in children, there is reduced adult supervision, which increases the risk of aspiration in this age group. The anatomical changes in the pediatric airway, high position of the larynx and epiglottis, narrowed airways, and incomplete development of airway protective reflexes all contribute to this problem. Majority of the foreign bodies are lodged in the bronchial tree, the right side being more common than the left. The rest others lodge in the larynx and the trachea. The clinical presentation depends on the type of foreign body, the duration of time after aspiration, and the exact location where the foreign body is lodged. Patient can present with wide spectrum of clinical symptoms ranging from a totally normal asymptomatic child to a child in severe respiratory distress. There are in 3 phases which the child presents, or the child present in one phase will progress from one phase to the other. The first one is the immediate phase. This is seen soon after the episode of foreign body aspiration. Child will present with choking, gagging, coughing, wheezing, stridor, and dyspnea. Parental recall of a choking, gagging incident with cough in a child is highly suspicious of a foreign body aspiration. This lasts for a very short time. During this period, the foreign body is either coughed out or lodges further down into the airways. After this phase is the asymptomatic phase. There is total relaxation of reflexes and reduction of symptoms. This lasts for hours to weeks. During this period, the child appears normal and the parent often forgets about this inciting incident. The last is the clinical or the complication phase. This phase, there is renewal of the symptomatic period. The foreign body produces erosion or obstruction. This leads to pneumonia, atelectasis, or abscess formation. There is renewal of symptoms in the child like cough, fever, wheeze, and hemoptysis. Depending on the site of lodgement of the foreign body, if the foreign body is lodged in the nose, the signs and symptoms are difficulty in breathing through the affected nostril, pain in the nose, irritability, especially in children, foul smelling, and bloody nasal discharge. If it is lodged in the larynx, cough, dyspnea, stridor, inability to speak, hoarseness of voice. If it is lodged in the tracheobronchial tree, then episodes of coughing, intermittent sinuses, intermittent dyspnea, intermittent hoarseness of voice. The signs are stridor, wheeze, unequal diminished breath sounds, and dullness of percussion. It is very, very important to note that a normal physical examination does not exclude suspicion of an airway foreign body. The diagnosis is based on the history of foreign body aspiration, the clinical presentation, and the investigations. Mainly the chest radiograph, high resolution CT, and fluoroscopy aid in diagnosis. Chest radiograph, PA and lateral views are taken, inspiratory and expiratory films are taken. This shows if it's a radiopaque foreign body, then we can identify the size, shape and location. Even atelectasis, emphysema and mediastinal shift can also be identified. In children, since it is difficult to take the expiratory films, lateral decubitus films are helpful. Coming to the management, first is to assess the severity of the situation. If there is a partial obstruction, that is, if the child is choking, the child has stridor and coughing, then cough is the best reflex to expel the foreign body out. Reassure the child and encourage cough, and at the same time check for worsening of symptoms of complete obstruction and try to shift the child to a medical facility as soon as possible. Now if there is worsening of symptoms and there is evidence of complete obstruction, that is muffling of sounds, no cough, and a child is not responding, then immediately, if the child is an infant, then we have to give 5 back blows and 5 chest thrusts. Sit on a comfortable chair, hold the child, turn the child and give 5 back slaps in the interscapular area. The chest now with the foreign body acts like a bottle filled with, blocked with a cork. The cork is the foreign body. With 5 back slaps, this increases the pressure inside the chest further, which will help in expelling the foreign body out. And now turn the patient, head and lowered again, mouth open, and give 5 chest thrusts like how we do CPR with 2 fingers in the mid-sternum just below the nipple line. This will also help in expelling the foreign body outside. Continue this maneuver several times till the foreign body is expelled out or till the child becomes limp and unconscious. Now, if the child becomes limp and unconscious, then start CPR, 30 chest compressions and 2 rescue breaths. After 30 chest compressions, before giving the rescue breaths, open the mouth, check for visualization of the foreign body in the airway. If it is visible, then only attempt to remove the foreign body outside with a finger sweep. Blind finger sweeps are not recommended since they may push the foreign body further down into the airway. Continue this till the foreign body is expelled out or return of spontaneous circulation. Now, if the child is more than 1 year of age, in an elder child, then Heimlich maneuver has to be performed. Stand behind the patient, place the hand around the patient's waist, make a fist, place the fist between the umbilicus and the xiphisternum, the other hand over this fist, and forceful abdominal thrusts have to be given in the upward and backward direction. This has to be repeated several times again till the foreign body is expelled out or till the child becomes limp and unconscious. If the child becomes unconscious, then continue CPR. If the child has reached the hospital in the meanwhile, then emergency cricothyrotomy can be performed with a 18-gauge needle or cannula. Oxygen supplementation can be given. IPPV can be supplemented en route to the operation theatre. Now, coming to the definitive management of a child with aspirated foreign body posted for bronchoscopic removal. Rigid bronchoscopy is the gold standard for foreign body removal. Flexible fiber optic bronchoscopy is an excellent diagnostic tool, and with minimal trauma we can diagnose the parenchymal changes due to foreign body aspiration. These are few cases we managed in our hospital. Now, how did we go about? Now, what are the measures to be taken before bronchoscopy? A good team effort is very, very important. Good communication and cooperation between the experienced surgeon and the trained anesthesiologist. 2 trained anesthesiologists preferably have to be present in the operation theatre. Equipment, monitors, suction, bronchoscope, proper size, even tracheostomy trolley, everything has to be kept ready. What are the anesthetic challenges? The child may be irritable or in a moribund state, full stomach child, shared airway between the surgeon and the anesthesiologist, difficulty in maintaining oxygenation and ventilation, which is already compromised, and difficulty pertaining to the pediatric airway. Our goals of anesthetic management are to maintain adequate oxygenation throughout the procedure, good IV access, maintain controlled cardiorespiratory reflexes during bronchoscopy and airway manipulation, rapid return of airway reflexes after the procedure, prevention of pulmonary aspiration and meticulous monitoring. If there is no evidence of complete obstruction, if the child is stable or minimal obstruction is present, then time is taken to fast the child according to the fasting guidelines, and preparation for bronchoscopic procedure is done. MLAC cream is applied to the child, and we try to take IV access in the presence of the parent. If the child is not cooperative or irritable, then we go for inhalational induction and IV insertion. Now, the choice of anesthesia depends on the site of lodgement of the foreign body and presence of or absence of the IV line. If an IV line is present, then we go for intravenous induction with propofol, 2 to 2.5 milligrams per kg body weight. Otherwise, inhalational induction with sevoflurane is continued. A topical anesthesia with lidocaine spray is done both to the vocal cords and to the trachea. This will prevent coughing on the scope and maintenance of airway reflexes. Now, if, for example, the foreign body is lodged in the upper airway in the cricopharynx, then spontaneous ventilation is continued with deepening of anesthesia with inhalational induction and supplemental doses of intravenous propofol if needed. Then under direct vision with direct laryngoscopy, foreign body retrieval with Magill's forceps is attempted. If it is not in the cricopharynx or upper airway, if it is lodged further down, we go for controlled ventilation with succinyl choline, 1 to 2 milligrams per kg body weight, and maintenance with either sevoflurane or propofol and atracurium 0.05 milligrams per kg body weight. Once the depth of anesthesia is maintained, then bronchoscopy is performed and care is taken. Good coordination and smooth performance of the procedure is done with adequate maintenance of oxygenation and ventilation. Once IPPV is continued through the ventilating port of the bronchoscope. Once the procedure is completed, then the child is woken up. After thorough oral suctioning, patient is extubated and supplemental oxygen is given. Now, jet ventilation is also one of the preferred choices for maintenance, but one of the problem is distal migration of the foreign body in jet ventilation and barotrauma. Now, there are several advantages and disadvantages of spontaneous and controlled ventilation. The few advantages are low risk of migration of the foreign body in spontaneous ventilation and continued ventilation during airway manipulation and foreign body removal. Disadvantages are the depth of anesthesia has to be maintained very well and risk of arrhythmias, hypotension and cardiac arrest is high. With controlled ventilation, the advantages, the patient is in a relaxed state and good working condition for the surgeon. Disadvantages of ventilation is not possible during airway manipulation and foreign body removal, and IPPV may cause distal migration of the foreign body. Post-operatively, we prefer to continue antibiotics if there is evidence of airway edema and inflammation. Cefixime 10 milligrams per kg, amikacin 15 milligrams per kg dose is continued. If necessary, if there is necessary, then our surgeon prefers to give metronidazole 15 milligrams per kg per dose. Short course of steroids, dexamethasone 0.08 to 0.1 milligrams per kg is continued for 2 to 3 days. Now, complications related to this procedure is due to either the lodged foreign body or due to the manipulation of the airway during bronchoscopic procedure. It can be airway trauma, laryngospasm, bronchospasm, dislodgement, pneumothorax, pneumomediastinum, stridor, to name a few. To conclude, early recognition and high suspicion of aspirated foreign body is very, very important to avoid ineffective medication and repeated administration in children, and prolonged presence of foreign body in the airway can cause irreversible pulmonary problems like parenchymal disease and pneumonias. Prompt and coordinated efforts between the team members is very important for a safe and anesthetic management of the child. And to note, normal radiographic findings and a non-agitated asymptomatic child does not rule out presence of an impending airway obstruction and compromise. Thank you.
Thank you.